Hey, what's going on, guys, and welcome back to another video of Keep It Simple Stupid. Today we're going to be discussing anaphylactic shock. We're going to be discussing what it is, how you diagnose it, and then we'll be discussing some of the pathophysiology and the treatment for it. Alright guys, so let's go ahead and get into it. So like most of these topics, I always think it's important to just discuss what is anaphylactic shock. So there's kind of two components to it. There's a timing component, and then there's also clinical symptoms that you need to pay attention to that can kind of clinch the diagnosis. So let's go ahead and get into that. Right, so step one is going to be the timing. It's important to understand that for anaphylaxis, you are going to have a very fast onset, and generally that's going to be between 1 minute to 1 hour. So now that we've gone over the timing for it, so between that 1 minute to 1 hour, let's go ahead and discuss, very importantly, the actual clinical presentation that you'll see in a patient. Now there's quite a few here, so I'm just going to go ahead and write them out. There we have it. I hope you can read my handwriting, but that's going to be kind of walking through the list here. It's going to be skin or mucosal involvement, generally going to be swelling, generally pretty diffuse, respiratory compromise. You'll see that either clinically the patient struggling to breathe, or you may see them being hypoxic on O2 sats. This is the big one here. Obviously for cardiovascular, it's going to be hypotension, so systolic blood pressure less than 90, diastolic less than 60. Interesting one here I didn't know about before I researched this, but persistent GI symptoms, or it can be isolated hypotension plus a suspected antigen. So for example, this patient's hypotensive and they just ate peanuts for the first time. So here's the two criteria. So you need two or more of the following on this side, or this alone, the isolated hypotension and the suspected antigen. That is your definition there for anaphylactic shock. Now, obviously, very important here, we're going to discuss treatment, in my opinion, between knowing what the presentation looks like and two, how to treat it. These are going to be the most important components of any medical complaint. So let's go ahead and get into it. And then we'll go ahead and get into it here. So the treatment, it's going to be, if you think historically like the EpiPen, then you'd be correct. So it's going to be IM epinephrine, generally a dose between 0.3 to 0.5 milliliters IM, or you can use an EpiPen, which is going to be a dose of 0.3 milligrams. Now, I think it's kind of important to discuss here that the epinephrine dose used for anaphylaxis is a 1 to 1,000 ratio. It's important to compare this to cardiac epi. Cardiac epinephrine that you would give a patient in cardiac arrest is going to be 1 to 10,000. But just remember that anaphylaxis, it's the 1 to 1,000 dose, and that is going to be intramuscular. And really, the only thing to know about what that means, like 1 to 1,000, 1 to 10,000, the important thing to know for 1 to 1,000, essentially that's telling you you have 1 gram of epinephrine in 1 liter. And then here's another question here. It's going to be why epinephrine for anaphylaxis? Why not steroids or antihistamines? These are great questions, and I'm going to go ahead and discuss some of the basic pathophysiology of anaphylaxis below, and then we'll kind of answer these questions a little bit. So here's my amazing drawing of the kind of two components to anaphylaxis, the cause, and then also we're going to be looking at the treatment and then why it works. So it's important to remember here, if you look at the top, that anaphylaxis, it's essentially an allergic reaction. And what do we mean by that? And you can just follow my purple kind of markings here as I go around and explain this. So if you think about an allergic reaction, right, step one is you have an antigen right here. And that antigen is recognized formed by the body. It's going to activate your T cells and B cells, and your B cells will produce IgE antibodies listed here in that green. So you're going to have your antigen, your body creates these IgE antibodies. Now the issue though is when these activate mast cells, and mast cells is what you see there in the blue, and a mast cell is filled with histamine. So say for example, you've been exposed to peanuts once, your body has developed antibodies against it, you're exposed to peanut again, and now you have an allergy to peanut. It's going to start with that antigen being attacked by that IgE antibody, which go ahead and activates a mast cell, which is right here. And those little blue dots, those are histamine being pushed out everywhere into the body. And if you look at my little drawings here, this kind of explains the general presentation of anaphylaxis and kind of the pathophysiology behind it. So what histamine does, it's a bronchoconstrictor vasodilator. So the histamine from those mast cells, they'll be attaching to these little histamine receptors. We'll just call them H1 and H2. And then I'll just kind of discuss what they are doing in each system. So if you think about vessels, right? So histamine is a vasodilator. So that's what you see here. You see that dilation of the vessels. Similarly, if we look at the lungs, we'll see we want our bronchioles to be nice and big, right? But what it'll do is it'll actually constrict, right? Making it smaller, which is bad for breathing, obviously. And then finally, we're looking at capillaries here. You're going to see a lot of swelling. Why is that? Well, with it being a potent vasodilator here, you're going to have capillary leak and the endothelial cells expanding. All right, so looking at this picture, you might think, oh my goodness, this doesn't look good. Now we're going to discuss how epinephrine, why this comes in handy. And we'll take it one system at a time. So say you have mast cell activation, you have histamine everywhere. How do we reverse that? So big key is going to be epinephrine. On the vascular side, epinephrine is a potent vasoconstrictor acting on alpha-1. So you can see here, it's going to act on your vessels and then also on your capillaries there. So if your epinephrine is circulating around, causing vasoconstriction in those vessels that have been vasodilated. And also it is a beta-2 agonist, very important. So as it activates the beta-2 receptors on the bronchioles, it's actually going to re-expand the airway and assist with breathing. Now, a good question is, why would you not use an antihistamine? Theoretically, you could. However, if you use an antihistamine, which I will draw in yellow, an antihistamine is going to be competing at the same receptors that are already bound off, okay? So you would have to use a very high dose of antihistamine to the point where it would potentially be a toxic dose. And that's my understanding of it. Now, what about steroids? You could use steroids, but remember that steroids generally take 4 to 6 hours, right, for roids. So you can certainly give them, they will reduce inflammation, but in the acute setting, epinephrine is going to be the key. And if you think about my little drawing here, epinephrine is actually working on different receptors than the actual histamine. All right, guys, that's all I have for you today. I hope this was helpful. Please like, comment, subscribe. Let me know if you have any questions. I'm trying to make an active effort now to continue to make more content. It's very difficult in residency because you get destroyed, but I'll keep trying my best. Thanks, guys. Talk to you next time.